Hello and welcome to the reprisal edition of the September 17th, 2020 edition of the Southern California Center for Oral and Facial Surgery Study Club, otherwise known as the Southern California Oral and Facial Study Club. We normally meet at Braemar Country Club here in Tarzana, California. However, we have been doing a live stream study club due to COVID-19. So those of you who joined us either from our study club or via onlineoralsurgery.com would, I'm sure, noticed that on the live broadcast, we were having some significant problems with not only our audio, but also the video portion of our live cast. And so it was less than ideal. A lot of people couldn't really hear the speaker. She kept going in and out, and as well as the video. So she's been gracious enough to re-record her lecture for us so that we can represent it again here. So I would like to introduce our speaker, Dr. Audrey Boros. She is a native of Canada and received her undergraduate degree, Bachelor of Science in Anatomy and Cell Biology at McGill University. She then went on to Queen's University and earned a Master of Science degree in Pathology and Molecular Medicine. She then started at USC Dental School and received her DDS degree. And followed that up with a 3-year oral and maxillofacial pathology residency at New York Hospital Medical Center in Queens, New York. She went on then to become a diplomat of the American Board of Oral and Maxillofacial Pathology and returned to Los Angeles, where she joined the faculty at USC Ostrow School of Dentistry. Became an attending physician, volunteer attending at LA County USC Medical Center in the Department of General Medical Pathology, and also joined the private practice known as Oral Pathology Associates for the USC faculty. And she's been in those 3 capacities for at least the last 10 years, as long as I've known her. She is an active member in the community and is a past president of the Southern California Academy of Oral Pathology, and she's incredibly knowledgeable and really a great lecturer. And so now I'm pleased to present Dr. Boros talking about some interesting cases in oral pathology. So Audrey, take it away.
Good evening, everybody. Thank you, Dr. Resnick, for having me, and thank you for joining. Today we're going to be talking about interesting cases in oral pathology. The goal of this lecture is to cover some of the basics that you might encounter in your practice, but then also some of the mimics that present like those basic entities. So I've got 6 cases, and we're going to be covering quite a bit of pathology today. I try and make it interesting, usually interactive, but that's a little bit difficult to do on a pre-recorded lecture. So before we get started with the cases, I do just want to cover some basic approach to oral pathology or oral lesions. The first step is obviously you've got to be able to recognize that something is abnormal. I think we're all pretty comfortable with that. Second is describing the lesion. This is really important. I'm going to touch a little bit about this in the next couple slides. I think this is important because it helps you approach the lesion, consider where perhaps the lesion is starting from. If the surface is interrupted, perhaps it's starting from the surface. If it's, smooth surface, then perhaps it's starting from underneath and growing upwards. So, and then each description has its own differential. So I think this is really important to try and get a basic grasp of describing oral lesions. Generation of a differential diagnosis kind of builds upon that description of the lesion. And remember, differential is basically a list of probable clinical diagnoses, so usually ordered from most likely to least likely, anywhere from 2 to 4. Differentials are helpful because it helps guide your clinical approach, and also it helps communication with the patient as well as with other clinicians. A definitive diagnostic procedure in the oral cavity in general, the standard of care is a scalpel biopsy, so that's usually what's performed, whether it's incisional or excisional, or perhaps a punch biopsy. And then basically the diagnosis will be the basis for recommendation for treatment, and then clinical follow-up is also something that's really, really important. So just general considerations. Don't forget that the patient is more than that lesion. It's really important, especially for the pathologist, to have as much information as possible on the patient. History of the condition, things I like to know, or I think about when I'm looking at a slide is, how long has it been there? What's the onset? Was it sudden? Was it gradual? Signs and symptoms associated with the lesion, including pain. Was there a history of trauma? What's the patient's medical history and medications, and social history? All those things can really help a pathologist kind of complete the picture, because a slide is a snap in time of something, but when we have a little bit more context, it really helps, and sometimes will help us not give you a descriptive diagnosis, but comment on, perhaps this could be XYZ based on history of the condition. Lesion parameters, also very important. So I like to talk about basic descriptors, which we'll cover in the next couple of slides, of a lesion, location of the lesion, don't forget, and if there's more than one lesion, even though you sampled one lesion, that's also really important to know. The color, so depending on the color, I have, my own set of differentials for each color for a lesion. The size, the shape, surface texture, like I said before, also important to note. Consistency and growth pattern. So all those things, you should be thinking about when you're looking at a lesion and approaching how to describe this lesion, including all those things in your description. So we're just going to cover some of these basic descriptors. So this is a small, less than 5 millimeter nodule, so small, less than 5 millimeters solid swelling. You see one on the lower labial mucosa here, or lip, and then a few of them on the skin on the right-hand side there. And so when it's smaller than 5 millimeters, we call it a papule. When it's larger than 5 millimeters, like we see here, again, a solid swelling, we call it a nodule. And if you want to take it even farther, you have this nodule, and you look at the base of the nodule. And if it's broad-based, we call it sessile. And if it's narrow-based, we call it pedunculated. Here's another basic descriptor I like to use. So lesions that have kind of finger-like projections or this kind of slightly rough surface texture. These are described as having a papillary architecture, so a raised lesion with many surface projections. The lesion here, obviously a little bit more papillary with those nice long finger-like projections. This lesion here on the upper right, a little bit more cauliflower-like. And both of those can be used, can be described as papillary, although sometimes people will describe more of the flat lesions as being verrucous. And if you're not sure, you can always use verrucopapillary and kind of combine those two terms. This is an example of a lesion where it is devoid of stratified squamous epithelium, the epithelium that lines the surface of the mouth, and the definition of that is an ulceration. So it's an area devoid of epithelium. So under the microscope, I'm seeing epithelium here all the way up to here, and then here I'm just seeing this fibrinopurulent membrane, which is that kind of yellowish hue, as well as vascularity and granulation tissue. These are flat pigmented lesions. These are macules. The differential diagnosis here ranges from a nevus to a melanotic macule to even potentially early melanoma. These are small fluid-filled lesions on the right here or left here, on the lower labial mucosa, lower lip area. And here we have a larger fluid-filled lesion, and so if it's smaller, we call it a vesicle. If it's larger, we call it a bulla, and that's the basis for the differential diagnosis of, the description of a vesiculobullous disease, where the differential diagnosis includes things like I'm sure you've heard of before, pemphigus, pemphigoid, and those are probably the two main ones that we'll encounter in the oral cavity. Just switching gears here a little bit, when we're talking radiographically, we have a kind of a diffuse presentation, so it's involving kind of a larger area, and it's more radio-opaque. So here's normal, this is abnormal. To take it even one step further, this is what we describe as having a ground glass appearance, which is often used to describe the entity called fibrous dysplasia. Here we have a lesion that is a periapical film showing a well-defined unifocal mixed radiolucent radiopaque lesion of the right posterior mandible between teeth numbers 29-30. It's hard to say, sometimes the radiographs are flipped. but in the posterior mandible, and this is obviously something that's radiolucent and radioopaque, so mixed. So when you're coming up with a differential diagnosis for a lesion like this, make sure that your diagnoses include things like adonogenic lesions or bony lesions or lesions in general that can produce hard material. And so something like an ossifying fibroma would be a really good differential here because that lesion has the ability to produce bone, whereas something like an adonogenic keratosis would not be a good differential because OKCs don't produce bone or any kind of hard tissue type material. Something adonogenic like a calcifying epithelial adonogenic cyst or a calcifying epithelial adonogenic tumor, that would be a good differential here because that has the ability to produce mineralized material. So just keep that in mind when you're coming up with differentials for mixed lesions. So this is an example of a unilocular, well-defined, corticated radiolucency. And then this is multilocular. So you've got all these smaller lesions within a larger lesion associated with an impacted tooth here, and the differential diagnosis, which we won't cover in this lecture, but in general for multilocular lesions, I like to teach about macho, myxoma, ameloblastoma, C is central giant cell granuloma, H is hemangioma, and O is OKC. And then once you start to learn a little bit more about each of those entities, you can stratify them based on the radiographic presentation or clinical presentation, or a little bit more detail about the case. Okay, and then I just wanted to touch a little bit on differential diagnoses. So developing a differential diagnosis. Two things I think about. One is etiology. So what is the, what is a potential reason for this lesion being here? And then the second thing I think about is the anatomy that's present. So as far as etiology, there's three main categories: developmental, reactive, and neoplastic. Developmental, we consider things like when we see something, or when we consider something developmental, we usually like to see multifocal lesions or lesions in a younger patient with multifocality or some kind of symmetry, potentially also involving other members of the family. So things like white sponge nevus, which is a developmental condition, or even leukoedema, or even getting farther into more advanced conditions like syndromes like neurofibromatosis, that kind of thing. So those are developmental conditions. When we approach adonogenic lesions, it gets a little bit confusing because some adonogenic cysts are considered developmental, so that's a little bit different type of developmental lesion because they are arising from remnants of tooth development. But in general developmental, we're thinking more genetic, younger patients, syndromes, that kind of thing. Reactive, we've got several subcategories such as autoimmune, infectious, inflammatory, and traumatic. So those are kind of my main reactive subcategories. And then neoplastic, it's not always black or white, but in general, when we think about benign and malignant, there are some entities that are benign aggressive. There are some entities that are very low-grade malignant. There are some entities that even under the microscope, nobody has a diagnosis for because nobody's ever seen it before, and so then it could be diagnosed as something like a neoplasm of uncertain malignant potential. But suffice it to say, just think about benign versus malignant. As far as anatomy, you need to think about the tissue type that's present. Epithelium in the oral cavity is going to be stratified squamous. Remember, when we're classifying epithelium in general, we classify the tissue based on the shape of the cell and the relationship of the cells to each other. So stratified squamous, stratified means many layers, squamous means flat. And so that's one type of epithelium, which makes up or comprises the skin and the mucosa of the oral cavity. Then you have other types like simple squamous, where you just have one layer of thin cells, where you'd find that in areas where diffusion needs to happen. So places like the lungs, the kidneys and capillaries. And I always like to tie structure with function because, you know, those things go together really, really well. As far as connective tissue, that's basically everything else. Oh, I forgot to mention that epithelium, glands are of epithelial origin, but they're found in the connective tissue. And that sometimes confuses people, but remember, malignancies of epithelial origin are carcinomas, so a glandular malignancy is an adenocarcinoma. Whereas for connective tissue, everything else basically falls under connective tissue. So you have your first subcategory of hard connective tissue and soft connective tissue. Hard connective tissue, bone, teeth, cartilage. Soft connective tissue, everything else. Fibrous connective tissue, of which there are many different subtypes, muscle, nerve. So, you know, if I have trouble coming up with, you know, different tissues in the area, I again start to think about function. How do I feel? How do I move the tissue, you know, in the area? So that's kind of how I approach how I approach developing a differential diagnosis. And the reason why I like to think about the anatomy is because pathology usually arises from normal anatomy that's present. That's not always the case, but it's a good place to start. Okay, so let's go ahead with our cases. So here we have a 65-year-old male, asymptomatic lesion of unknown duration noted by the patient's dental hygienist. And so just to describe this lesion, we see I like to include a measurement approximately, 2 by 2 centimeter, somewhat well-defined, but you're losing some definition in areas. But the main descriptor here for me is red and white, so an erythroleukoplakia, and partially ulcerated potentially here, of the lingual frenum, and that's a pretty good description for this lesion. Before we do that, I'm going to ask you why lesions appear white. So kind of just considering the other portion of that lesion. So we had the red lesion, the red portion of the lesion, and now the white portion of the lesion. And so here we have stratified squamous epithelium. I won't spend too much time on histology in this lecture, but it's important to know, you know, a little bit of the basics. Each one of these cells is called a keratinocyte, and there's many layers of them, and this is the keratin up here, perikeratin on the top. And so if you have too much keratin, which is this layer here, it's going to appear white in the oral cavity. And so that's mainly why lesions can look white when we're talking about leukoplakias. So the differential diagnosis for red and white lesions, and here again we have a pretty well-defined uniformly erythematous lesion that was considered an erythroplakia because there were no, after workup of the patient, there was no evidence of trauma. And then here's another really good example of a leukoplakia where you have really well-defined margins. And when you have such well-defined margins in a white lesion such as this, that increases my suspicion for the lesion being dysplastic over, say, something like trauma or hyperkeratosis. And this is relatively homogeneous, well-defined, pretty large lesion of the right lateral border of the tongue. So your differential for both red and white leukoplakia, so for erythroplakias and leukoplakias, are very similar. So reactive, dysplastic, or a squamous cell. And so remember, reactive, you have many of those subcategories. For example, you know, the first thing you might think of on this red lesion would be something like a burn, like aspirin burn, or a pizza burn, or something like that, or, you know, localized inflammation for whatever reason. Here, it might be the patient's got a sharp cusp in the area, and the tissue is producing more keratin. And then dysplasia and squamous cell. So those are your differentials for red and white lesions in general. For those of you that are less comfortable with histology, we can focus on the top here. On the bottom, it's the histo. But in general, just to cover dysplasia quickly, if everybody's not super familiar with it, normal epithelium, basement membrane here, connective tissue. When cells become dysplastic, they start to look funny and they act funny, and it's basically considered a precancer. And once the precancer is involving the entire thickness of the epithelium, we call that carcinoma in situ or carcinoma in place. But very importantly, once it breaks through this basement membrane, it has access to the blood vessels, and now it's considered a carcinoma, and it has the potential to metastasize. Whereas if that basement membrane is intact, there is no potential for metastasis. So the biopsy results for this case was squamous cell carcinoma. And I'm just going to cover a little bit of detail about squamous cell. So even on this slide here, we see that the heading is oral cavity and oropharyngeal squamous cell carcinoma, and we do that on purpose. The data is still combined, so here's for 2017 American Cancer Society. So we still combine this data, but the more we're learning about these two types of squamous cells or two different locations, the more we are, I think, going to trend towards separating the data, because they are in fact very different diseases, even though they are both squamous cell carcinomas. So an estimated 53,000 cases in the US per year, with almost 11,000 deaths. Males more commonly affected than females, and it's about a 62% 5-year survival rate, which hasn't changed in decades, and the 8th most common cancer in men. The risk factors when I was in school, smoking, drinking, older male, those were really the risk factors. In some subpopulations, federal quid chewing and chewing tobacco were also considered to be risk factors. Sunlight for the lower lip. A lot of the times, chapped lip or chapped appearing lips are actually actinic cheilitis, and that's a precancerous condition. And then HPV more recently, and that's something I'm going to talk about a little bit more. So in general, the high-risk sites are still the same: lateral border of the tongue, floor of mouth, ventral tongue, but the cancers, the squamous cells that arise in the soft palate and tonsillar pillar area, those are more likely to be related to HPV. So I'll just touch a little bit on HPV. 80 million total HPV infections per year, so it's very ubiquitous. 6 million new individuals infected per year. 80 million total HPV infections, with 6 million infected per year. 80% of Americans will have an HPV infection in their lifetime. Most of these, the overwhelming majority, are going to clear that infection. But there are a subset that will develop an HPV-associated malignancy, and this number has actually increased since I made this presentation. It's, actually head and neck squamous cell carcinoma is outnumbering, related to HPV, is outnumbering those now of cervical cancer related to HPV because of the vaccine. There's many different types of HPV, almost 200 different genotypes. They're classified into low risk or non-oncogenic. Those are things like papillomas, even condylomas are considered low risk, and then oncogenic or high risk, which are usually type 16 and 18, and those are the oncogene or the virus subtypes that have the potential to develop squamous cell carcinoma. So if we look specifically at high risk HPV, you find that most of the squamous cell carcinomas that arise in the oropharynx are HPV associated. So, maybe upwards of 80%. Whereas the oral cavity proper, anything, anterior to the base of the tongue and the soft palate, usually not HPV related. So something like 2, maybe 5% of those cases will show HPV positivity. So in general, the more farther back you go, the more likely is HPV related. The more anterior you go, the less likely is HPV related. This was an interesting study that was done in 2011, and it basically showed the incidence of oropharyngeal squamous cell carcinoma is increasing. And this study specifically only found 30%, but there are numerous other studies that show anywhere from 30% to more than 100% increase depending on the years and the population that's studied. Primarily, this is found amongst younger men and often diagnosed at a late stage, at least back in the early years where this was starting to become a problem, because it wasn't considered a disease or a squamous cell carcinoma of young men, and so it wasn't something that was high in the differential diagnosis list. But this study also showed, interestingly, the proportion of HPV positive oropharyngeal squamous cells was increasing. So, labs are required to keep biopsy samples for, 5 to 10 years, depending on if it's a block or a slide. And so sometimes labs keep the tissue indefinitely. And so this group went back, looked at different tissue samples, and stained them for HPV, and they found that in the 1980s only 16% stained positive for HPV, and in 2000s it was 73%. And it's a DNA virus, so it's not going to degrade that quickly, so that's not an issue. And so we just see more of this as the years progress. And so now, clinically translating this information, you can basically just break it down into, there's kind of 2 at-risk populations: HPV negative squamous cell carcinomas associated with classic risk factors, usually older than 40 years, and classic high-risk sites. And then there's that HPV positive at-risk patient with younger patients ages 20 to 44, non-smokers, non-drinkers. And usually these cases, like I said, are present in the oral pharynx. So I'm just going to compare oral cavity to oropharyngeal squamous cell. So the appearance, these are different cases. So again, oral cavity squamous cell, the case numbers are remaining stable, relatively stable, usually seen in older male smokers and drinkers. In the oropharynx, the cases are increasingly at kind of an alarming rate in younger males and is HPV associated. So here we have an ulceration of the floor of the mouth ventral tongue that is classic smoker, drinker, older male, squamous cell carcinoma. Here we have a more granular type kind of erythematous lesion of the tonsillar pillar, and this was a squamous cell HPV related. You can see similarities here again. So these are non-painful lesions, so it's really up to us to find them, hopefully sooner rather than later. They only become painful when they're really advanced. Here in this case is a younger patient, as you can tell by their dentition, and again, lateral border of the tongue, non-HPV related. Here is a case where the dentist was diagnosed this area as having advanced localized periodontitis, extracted the tooth, placed an implant, restored the implant with a crown. Meanwhile, there was a squamous cell carcinoma that had to, I am assuming, although I don't know for sure, that the diagnosis of advanced periodontitis was possibly incorrect, because look at the rest of the dentition, it's very good. And so potentially it could have been a squamous cell all along that was growing, but mistaken for granulation tissue or periodontitis. And squamous cell carcinoma of the gingiva can really mimic periodontal disease. So just keep that in mind. Always submit tissue for biopsy for definitive diagnosis. Don't throw tissue like this away, because you don't want that to come back. And not only that, but also you want to catch these cancers as early as possible for the betterment of the patient. Here's another HPV-related squamous cell. So looks a little bit different, more ulcerated, but in that same area, so back of throat. And this is a great example of squamous cell carcinoma masquerading as periodontal disease. It's not wrong to scale these teeth, but it is incorrect to keep scaling and scaling and not seeing any improvement, and keep doing the same thing over and over again. So if that, if you scale and it doesn't improve, think outside the box and consider taking a biopsy, because you think it's periodontal disease, but it might in fact be something else. So it's so important to think outside the box and not keep doing the same thing over and over again, expecting different results. Here's a more classic example of a squamous cell of the gingiva. A good example of a non-HPV related squamous cell of the ventral tongue floor of mouth area. Again, this would not be painful. A really great example of lateral border of the tongue squamous cell carcinoma. Differential diagnosis here would include a traumatic ulcer. And I've seen some traumatic ulcers that really mimic squamous cell carcinoma. So sometimes the only way to get a definitive diagnosis is for biopsy. And here's another more diffuse erythroleukoplakia of the left buccal mucosa extending into the vestibule. So this is a large lesion. This is a case that might be considered having a clinical diagnosis of what we call proliferative verrucous leukoplakia. I know that this patient was treated for a very long time as having lichen planus. This is not what lichen planus looks like. It doesn't have this, verrucous type, very white appearing presentation. And if you take nothing else out of this lecture, just remember that lichen planus is multifocal. And so here we have a one area that's contiguous and way too verrucous to be lichen planus. So this is something called PVL, and histologically this would be diagnosed as a squamous cell carcinoma or advanced dysplasia. And the last slide for this case, I just wanted to talk about prognosis. So if we're looking at 5-year survival rates, we have oral and oropharyngeal squamous cell carcinoma. If we break it up all stages, so put all these stages together, we break it up into local, so primary site, regional, lymph nodes, distant metastasis, and then we look at the different types of cancer, we can see that oral and oropharyngeal cancer has a similar 5-year survival rate as colorectal cancer. But if we compare it to, say, melanoma, we see that melanoma is 91% at 5 years. So 91% of patients survive at 5 years that have been diagnosed with melanoma. And the reason why this is so high is because it recapitulates this local stage of disease, meaning that dermatologists are aggressive when they see pigmented lesions and they biopsy them. They don't delay the biopsy, and most of those cases are early or are cured surgically. And so that is a good thing, and that accounts for why there's such a high 5-year survival rate with melanoma. If we look at oral and oropharyngeal cancer, 65% is closer to the regional number of 57%. So that means that we're catching these cancers when they've already spread to the lymph node, which obviously does not correlate with a good patient outcome. So what we can do to control this is be able to find these lesions early, biopsy these lesions, and take them out before they become cancer. So or at early stages of cancer where surgery itself would be curative. So secrets to success here: look for red and white lesions. Remember your differential diagnosis is trauma, dysplasia, and squamous cell. Squamous cell carcinoma has 2 demographics now: older men, smokers and drinkers, and then younger men, non-smokers and non-drinkers. And then I just put in really big letters here, like I'm screaming to you, early detection saves lives, and it really does. And unfortunately, I'm in the position where I see a lot of the later cases that have grossly delayed diagnoses, and patients don't do well. So let's try and find these lesions earlier. This case, I'll wait for the radiographs. I have some radiographs after. It was a young patient, and the lesion was asymptomatic. So the differential diagnosis here, when you see bumps of the gingiva in general, we have our differential of the 3 Ps. And this, you can think about pyogenic granuloma as having being of vascular origin. So you're thinking about the tissue type that's there, vascularity. Peripheral ossifying fibroma, a little bit more difficult to pinpoint the tissue type that's there, but I guess fibrous tissue as well as some bone. And then peripheral giant cell granuloma. Giant cell is not something that you might think of normally in the area, but this is one of those exceptions. And it's just good to know bumps and lumps on the gingiva. Your go-to differential is the 3 Ps. 99.9% of the time, it's probably going to be one of those, or maybe even, parulus or a peripheral adonogenic tumor. Significantly. And this is a round blue cell tumor. So here's our epithelium, here's our fibrous connective tissue, and here is our tumor. And any round blue cell tumor, we have a whole histologic differential diagnosis that we need to consider, and we sub-classify it based on immunohistochemical stains, and this was stained as a lymphoma. So this was a lymphoma. There's 2 main subtypes, Hodgkin's and non-Hodgkin's. If it's non-Hodgkin's, there's B and T cell subtypes. Hodgkin's, there's 5 or 6 different subtypes of Hodgkin's lymphomas. You can also classify lymphomas based on their location. So is it nodal, involving the lymph nodes, or is it extranodal, not involving the lymph nodes? And when you think about lymphomas, the tissue of origin is a lymph tissue, right? And lymph tissue moves around your body everywhere. And so you can really develop a lymphoma anywhere in your body, in the bone, in the soft tissue, in the lymph nodes, in under your toe, anywhere. So just consider that, and it's very, very important to subclassify the lymphomas, because the specific type of lymphoma, here is a list of some of the different types of lymphomas, the WHO classification from 2008. The subtype is very dependent. The treatment is very dependent on the subtype of lymphoma, and that's a whole different specialty. So when I would say that lymphomas are the second most common diagnosis I make in the oral cavity behind a squamous cell, and when I see that it's a lymphoma, I send it off to a hematopathologist so they can run their stains and extra genetic testing, so they can really be confident which type of lymphoma we're dealing with, so we can get the patient the best treatment. I like to say that lymphoma is the great mimic. Here's another case that was a lymphoma. Again, this is not, I'm not jumping to lymphoma here in my differential diagnosis. I would consider the 3 Ps here. But remember, I said that 3Ps, peripheral, don't involve bone. So when you flap the tissue and you see that there's bone involvement, you've got to think outside the box, because it's probably not, it will not be those 3Ps unless it's something like a central giant cell granuloma that's busted out into the periphery. This was also a lymphoma. This is the most common location for an extranodal non-Hodgkin's lymphoma in the oral cavity, so a palatal lesion just like this. Just touching upon metastatic disease to the oral cavity, just because it can mimic those 3Ps as well. This is a GI metastasis to the oral cavity. It looks a little bit like a pyogenic granuloma, but I have a higher index of suspicion because it looks like it's going on to the lingual as well, and there's lots of necrosis, which is this kind of top layer here. These are squamous cell carcinomas that were mimicking pyogenic granulomas. You know, if a pyogenic granuloma was this large, it probably would be pedunculated. And then look distally here, there looks like the tissue looks like it's also involved. So, you know, looking subtly at these lesions, I definitely favor a squamous cell over something like a pyogenic granuloma, but I know both of the clinicians here submitted the biopsies, and their top differential was a pyogenic granuloma. And in both instances too, the clinician was working on the teeth in the area on crowns, and you know, the diagnosis was delayed because they hadn't biopsied the lesion right away. They thought it was granulation tissue. So squamous cell carcinoma, a little bit more, you know, earlier presentation, and also mimicking a pyogenic granuloma here. This clinician, this was a 20-something-year-old female. This clinician knew this patient very well, knew the hygiene was very good, nice stipple gingiva, wasn't pregnant, didn't have any reason to have a pyogenic granuloma in the area, and so this case was diagnosed very early, and it was biopsied right away, and it was a squamous cell carcinoma. So secrets to success for gingival nodules. Most of the time, they're going to represent the 3Ps: pyogenic granuloma, peripheral ossifying fibroma, peripheral giant cell granuloma. There are a couple other Ps to consider, like a parulus or an abscess, the same thing, and a peripheral adonogenic tumor or a peripheral adonogenic fibroma. But malignancies, keep in mind that malignancies can mimic these benign lesions. Lymphomas, like I said, are the second most common malignant diagnosis I make in the oral cavity, and the gingiva is the most common site for soft tissue metastatic disease, which can also mimic those 3Ps. Okay, case 3, we have a 60-year-old female with intermittently painful gingiva of 1-year duration. So the first thing that I notice here, and probably you're noticing, is there's a lot of plaque accumulation. The gingiva are diffusely red here, and I'm sure that most of you are thinking, you know, probably gingivitis secondary to this plaque. But in fact, this patient was in so much pain by this point that she was unable to brush, and so that is why there's so much plaque accumulation. It's not because you know, she wasn't brushing, you know, just because she didn't want to or whatever. It was because these lesions were so painful. When we see this kind of a presentation, you know, remember erythema or redness, increased inflammation. The tissue is like this because there's either increased inflammation, increased vascularity, loss of keratin, loss of tissue, which is ulceration. So you can have superficial ulceration, you know, so any one of those things. And so when it's diffuse like this, I'm thinking more of a reactive condition, not something neoplastic or developmental. And so reactive also because it's painful. And so now I have to start thinking about gingival conditions that are reactive that can present like this with pain in a middle-aged female. And so my differential diagnosis, when I see that kind of diffuse red gingiva, is we describe it as being a Disqualmet of Gingivitis, and the differential is this. So erosive lichen planus, Lycanoid Gingivitis, pemphigoid, and pemphigus. And those are all, these three are immune-mediated conditions, and this is an allergy, usually caused by systemic medications, but not always. So here we have the biopsy, and we have, you know, my heart kind of sinks when I see this because I don't have any epithelium. I only have connective tissue and ulceration. And in order to make a diagnosis on something like this, I need to see the epithelium. So I looked really carefully, I got some deeper recuts, and I found some epithelium. And so I was really happy about that. But then my heart sank again because some of the features of this biopsy looks like pemphigoid, where you see a subepithelial split, you're seeing the epithelium splitting, right? Some of the features actually also look like lichen planus, where you can get splitting and you have this inflammation, which you have here. So sometimes, especially when you take a biopsy of the gingiva of these conditions, it's useful to also include a DIF specimen. The reason why it's a little bit more tricky to make a diagnosis of one of these conditions on the gingiva as opposed to, say, if you took the biopsy from the buccal mucosa is because of that concomitant gingivitis that might be present with all the plaque and everything there. That obscures what we're seeing under the microscope. All that inflammation is just generalized. It takes away from the features that we're looking at if we were to, say, make a diagnosis of lichen planus or pemphigoid. So oftentimes for gingival biopsies, when you have the differential diagnosis of a Disqualmet of Gingivitis, I recommend submitting an H&E biopsy, so regular biopsy as well as one in Michel solution. You cannot ask for DIF or direct immune fluorescence if you put the specimen in formalin because it has to be in Michel solution. So you've got to be organized. So this was mucous membrane pemphigoid. This patient had pemphigoid, and I see this very often. I practice oral medicine in Santa Monica, and I'd say one of the more common diagnoses I make is pemphigoid. And even with erosive lichen planus, you know, these patients go from doctor to doctor to doctor to doctor, and nobody seems to be able to figure it out. And it's, you know, because I think people don't think outside the box. They think they see red gingiva, they see a lot of plaque and calculus, they think it's gingivitis. But if it's not, the gingiva are not responding the way that you would expect, then you have to think outside the box and take a biopsy. So this is considered a chronic autoimmune mucocutaneous vesiculobullous disease. So that sounds like a mouthful. It's chronic, so it's not going to go away. Autoimmune, so it's immune-mediated. Mucous membrane, cutaneous, skin. Vesiculo, small little bubbles. Large bubbles, bullous, disease. So you're just breaking that word down. Females greater than 40 years of age, which is our patient. Painful. Sometimes people have really high pain thresholds and describe it as not being painful. With or without vesicles, usually the vesicles burst on the gingiva because there's so much trauma to the area. So you would be very lucky to see a vesicle in reality. Predilection for the gingiva, and you do need to biopsy for definitive diagnosis because the differential, the treatment is different for each one of those entities. Remember that pemphigoid can involve the eye, can lead to blindness if there's recurrent scarring, and so treatment, and so what I do when I make a diagnosis of pemphigoid under the microscope is I comment that the patient needs to be evaluated by an ophthalmologist and a dermatologist, and watch out for GI conditions as well, because pemphigoid can affect the GI system. This is something that where earlier treatment usually correlates with a better response, and if the treatment, and if this condition is untreated, it can be fatal, and so you will always want to just make sure that you're working in tandem with the appropriate specialists as well. Disqualmet of Gingivitis, just the other entities, lichen planus, probably the most common thing I see in my oral medicine practice, can look very similar. Again, you can't make the diagnosis most of the time you can't make the diagnosis just if it's involving the gingiva. It's the differential diagnosis, lichen planus, pemphigus, pemphigoid, you need a biopsy. If it's involving the buccal mucosa like this, then I feel more comfortable calling this lichen planus. This is very typical Wickham striae lichen planus, and if I see this picture together, I might treat it clinically as lichen planus, and if it's not responding the way that I would expect it to respond, then I might take a biopsy for confirmation. Lycanoid gingivitis, in this instance, it was related to the amalgam in the buccal mucosa where it was replaced and this lesion disappeared. And then also lupus can look a lot like lichenoid gingivitis or lichenoid mucositis or lichen planus. And so again, here's where, you know, it's helpful to include medical history in your pathology biopsy submission, because if we don't know that, you know, we could very easily overlook that because all these entities can look very similar, especially if they're all from the gingiva. The only difference with lupus is that there's a very thick basement membrane, which I'm highlighting here. And so it can look a lot like lichen planus. So secrets to success here: serious conditions can masquerade as gingivitis. If the tissue is not responding to periodontal measures, think outside the box. Just thinking about the tissue types that are there. The overlying mucosa looks good, so it's coming from underneath. What kind of tissues are in the area? There's nerve, there's blood vessels, probably not vascular because there's no change in color in the overlying color, so it doesn't look red or purple. There's salivary gland tumor or salivary glands in the area. There's fat in the area, could be that, could be many different things. So my differential was a benign soft tissue tumor, so it's kind of an all-inclusive, nerve, fat, vascular tumor, fibrous tumor, and then a benign salivary gland neoplasm. Have to consider that, especially because of the location, and also because of the location. If you're including a benign salivary gland tumor, you have to include a malignant one, because just statistically, it's 50-50% chance if that is a salivary gland neoplasm, it's benign versus malignant. And so biopsy was taken, and this is the histologic picture of an adenoid cystic adenocarcinoma, which is a pretty aggressive, relentless salivary gland malignancy. And so adenoid cystic carcinoma is malignant. It has a tendency to grow slowly but relentlessly. Because of that, it can mimic a benign tumor, and it likes to grow along the nerves. Usually 55% of the time it'll occur in a major gland, but if it's going to occur in the minor gland, the hard palate is the most common site. Remember, we have minor salivary glands everywhere in our mouth except our attached gingiva. When you have lesions elsewhere in the mouth, don't forget about salivary gland origin for tumors. Usually women are affected more commonly, and adults in the 4th to 6th decades. So this was her biopsy, and this was her treatment. So it was a radical excision, radical resection, and I know that she was very actually thankful, and she wrote us a letter thanking us that we made the diagnosis relatively early. Just a little bit more about salivary gland tumors. If you consider all types, major and minor gland involvement, benign is more common than malignant. If you only look at minor salivary gland tumors, which are the ones that we will see most commonly, benign and malignant about 50-50. Minor salivary glands are everywhere in the mouth except the attached gingiva. So if you have a lesion like that looks like a mucocele of the gingiva, it's probably not a mucocele. It might be something like gingival cyst. So salivary gland tumors, percent malignant by site. This is really important for you to develop a good differential diagnosis to know this. If you are looking at the parotid gland, about 1/3 of them are going to be malignant, so 2/3 are benign. Submandibular, you're increasing your number a little bit, but I like you to pay attention to these numbers here. If you have a nodule of the tongue, floor of mouth, and retromolar pad that has salivary gland features, and so you're considering a salivary gland tumor, 70 to 90% of the case of salivary gland tumors in this location are malignant. Palate, like I said, is 50-50. Lower lip. Most of the time you're going to have reactive lesions of the lower lip that are of salivary gland origin, like mucoceles or even mucus cysts. But if it is a true tumor, 66% of the time it's going to be malignant. So with knowing that, there are some malignant lesion salivary gland tumors like a mucoepidermoid carcinoma that can present like a mucocele. And so that's why we always recommend taking biopsies and submitting that tissue for microscopic analysis of lesions, even if they seem like routine mucoceles, because mucoepidermoid carcinomas can look like mucoceles clinically. They have a lot of mucin in them if they're low grade. And then the opposite is true for the upper lip. If you have a salivary gland tumor, like a true tumor of the upper lip, it's usually benign. And this is a great example of a lesion where you have a bluish hue submucosal mass. What can make the tissue look blue? I'm thinking neoplasm here, or reactive, not developmental. And what can make the tissue look blue? What's the anatomy that's there? So vascularity and salivary glands. So mucin. Those are my top two. And then since I'm thinking salivary gland, got to include a tumor if there's no history of trauma. Tumor, this location, 70 to 90% of the time is going to be malignant. So I favor a malignancy over something benign. So I would biopsy this lesion probably that day if this patient presented in my office, knowing what I know. Never leave a lesion like this in the upper lip, even if there is a 10-year history of that lesion. So secrets to success here: perform routine, thorough oral cancer screening exams on every patient every time. I know sometimes that's not possible, but at least every 6 months. And look and feel, because lesions can be subtle and sometimes only felt on palpation. Okay, moving on to case 5. This is a lesion of long-standing duration. Patient had declined surgery several times and would drain the lesion himself. Differential diagnosis here, remember the definition of a cyst. I'll just go here, is an epithelial lined cavity. So my differential there, I'm thinking cystic. So dentigerous cyst, which would be the most common. So glandular adonogenic cyst is something I would also consider in that location and in that demographic. And then adonogenic keratocyst. You could also include a cystic ameloblastoma in your differential, but I didn't favor that because of the patient's age. And so there's are my differential. And the way that I can tell these different cysts apart is by looking under the microscope, and I look for different features. So say for example, adonogenic keratocyst is going to have 5 to 7 cell thickness of the cystic layer with perikeratin on top and a nice palisaded basal cell layer. Glandular adonogenic cyst, we have to see other specific features in that cyst lining, whereas dentigerous cyst kind of usually just can range from simple cuboidal epithelium, which mimics the follicular tissue, to inflamed stratified squamous epithelium. So it's really the cyst lining, the features of the cyst lining, that determines what type of cyst it is. And so here are examples of, this was a dentigerous cyst, this was an adonogenic keratocyst, this was a glandular adonogenic cyst. So, you know, they can all look very similar, which is why, you know, biopsy is indicated for lesions like this, because treatment differs for all 3 of those entities. So here's our histology. I won't touch too much on there, but I see some purple here, inflammation, maybe some cyst lining, epithelium here, which is a little bit strange, so I'm going to focus in on that. I'm seeing some epithelial islands within the connective tissue cyst wall, which is strange. I'm focusing a little bit more here. So there's some keratin pearls. Some of the cells are starting to look large and funky, and they're dyskeratotic and large nucleoli. Even maybe some mitotic figures. Right here we see a mitotic figure. And so this was actually a squamous cell carcinoma arising in a dentigerous cyst. This is obviously very uncommon. Most of the time it's going to be any of those 3 differentials that I provided. So a dentigerous cyst, glandular adonogenic cyst, OKC or cystic ameloblastoma. But this was a squamous cell arising in a dentigerous cyst, which can happen because cyst lining is of epithelial origin. It's very rare. Increased probability with long-standing lesions like this patient kept draining the area repetitively over decades. Most have been reported arising in a residual cyst, but this is a good example of why to submit all cystic tissue even if it looks routine, because there wasn't really much on that radiograph where I would have, you know, relayed to the clinician that I was worried about something malignant. Okay, and then finally our last case. I love this case because it's, you know, just something that kind of blew us out of the water. Okay, this was a 55-year-old male, asymptomatic lesion, discovered on routine exam. The patient was a smoker for many years and had a similar lesion on the soft palate. So when you're looking at this, this patient's buccal mucosa, you see that there's kind of like diffuse pigment and then these white areas. And so the clinician and myself were concerned about the white areas because the patient had a history of heavy smoking. And so, you know, Leukoplakia, been there for several years, fairly well defined, which is a feature I look for to favor dysplasia over trauma, and multifocal. We just wanted to make sure we knew what it was. We were considering just pigment. The pigment was, you know, likely secondary to smokers, maybe smokers melanosis or some kind of post-inflammatory pigmentation. Remember that pigment is produced by melanin, the melanin pigment, but it's stored in the keratinocytes. So if you damage the mucosa and the keratinocytes, it can spill into the submucosa and stay there and stain the tissue brown. So what can make the tissue look white? So we covered that already. Hyperkeratosis, there's some kind of trauma to the area, dysplasia, or squamous cell. I was more considering hyperkeratosis or dysplasia just based on the localized presentation and fairly monotonous presentation. But what can make tissue look brown? You have to consider amalgam as well. So exogenous pigment, melanin, and then hemorrhage. So potentially also, a bruise that's resolving. So this was the biopsy. Biopsy was taken. You can see this, this is the normal just to compare to the biopsy. You can see there's hyperkeratosis here. So that's, this biopsy has too much white here, too much keratin, which is why the tissue looked white. But, you don't have to be a pathologist to recognize that there's something going on at this junction. At the junction here. You don't see it here. It's a nice clean junction. There are kind of pockets of cells, collections of cells, and some of them are even going up to the surface, which is a little unusual. So I'm looking at these cells, and each one of these are a keratinocyte, but the cells that have these kind of halos around them, these are actually melanocytes. And we never like to see confluence of melanocytes, which you're seeing here all throughout. And then we also don't like to see weird looking cells that look like melanocytes within the connective tissue. There's some pigment here. There's a cherry red nucleoli, which is something that's kind of scary to me. Here's another example of a very atypical type of melanocyte with a cherry red nucleoli, really large nucleoli, 3 nucleoli here, terrible cell, 4 here. So in here too. So all of these cells look very, very atypical. And when you have these atypical cells going to the surface, we call that Pagetoid Spread. And histopathology, we had to confirm the diagnosis because we could almost not believe it. And it was that presentation was an oral mucosal melanoma, believe it or not. So we didn't until we saw the histology. Oral melanomas are aggressive, often diagnosed at a late stage. Early lesions like these, like the one that I showed you, mimics benign lesions. They're high-risk areas. High-risk areas are the hard palate and maxillary gingiva. Do not delay biopsies in these instances because the early lesions mimic benign lesions. My rule is, and the protocol that I follow is, if I see a pigmented lesion on the hard palate or maxillary gingiva and I don't have radiographic evidence of exogenous pigment like amalgam in the area, which you can oftentimes see on radiograph, I recommend a biopsy because that's what I would want in my mouth. With the knowledge I have, that's what I would want. You don't want to wait until it looks like something like this because the fact that this is nodular already means it's probably metastasized. Clinically, they can develop rapidly or slowly, depending on their growth phase. So if they're stuck in a radial growth phase, they can have a very slow progression. That means they're just growing horizontally. Once they start to gain the vertical growth phase, that means that they're going to start growing rapidly and very high chance of metastasis at that point. There are a subset of people, especially within the oral cavity, that it's generally accepted that these don't arise from pre-existing nevi. So even if it's the pigmented lesion has been there for a long time, it's probably a typical melanocytic lesion that then develops into a melanoma in situ and then into a melanoma. But this is arguable for the skin. Rapini et al. So there's a study that found that, shows that 75% of the cases will occur on the palate maxillary gingiva. I've only ever seen this one case primary to the oral cavity on the buccal mucosa. The overwhelming majority are going to be on the palatal gingiva, maxillary gingiva, and palate. And here's an example of a melanoma here. Pigmented lesion here, but you can also, if you look closely, see it everywhere, so it's starting to spread. Another example of a melanoma, this is more typical. Same thing here, very dark pigmentation. Hopefully everybody would be very concerned about all these lesions. This, a little bit, more tricky. You have a little pigmented lesion here. This is also a melanoma, but it's called an amelanotic melanoma. The lesional cells have become so dedifferentiated that they can't even produce melanin anymore. So this is a very aggressive type of a melanoma. Again, kind of mimicking one of those 3 Ps. This is, again, why I like to biopsy the lesions where I don't see radiographic evidence of amalgam. This was a melanotic macule. This was a melanoma in situ. So we want to make sure that we're biopsying these lesions early because they are very aggressive. Don't forget to examine the skin. This was a melanoma on the skin. So, you know, again, like I said before, we see patients more often than their dermatologists, most likely. So it's, you know, you're doing a great service to them if you can just examine their skin. You don't have to know the diagnosis, but just, you know, recognize abnormal and refer. So conclusions here in general, extraoral and intraoral exam on every patient, every time, should be every time, sorry. Look and feel. So remember that case where, you know, it was only, you were only able to palpate that lesion as opposed to see it clinically. Serious lesions can masquerade as benign lesions. We covered a whole bunch of benign lesions, but then made the cases interesting because these, there are serious malignancies that can mimic benign lesions. Differential diagnosis. So come up with a differential. To come up with a good differential, think about the etiology and the tissue type that's present. And the 2-week rule didn't really touch on that, but if a lesion is still present after 2 weeks, you know, you really should biopsy the lesion for definitive diagnosis. Okay, and that's it for tonight. Thank you so much for joining me. I hope you guys learned something.
Thanks, Audrey. That was really great, and I really appreciate what you've said to everybody about not only examining by look, but also examining by feel or palpation. You really can miss a lot of lesions if you don't look at both. So our next study club meeting is going to be on October 15th of 2020, of course, next month. And we were originally planning to have Dr. Stuart Hoffman, who's a local orthodontist, talk about pitfalls and pearls with Invisalign. However, he's not able to make it, and so we're really honored to have a substitute lecturer, Dr. Kathy Hayes, who is not only has her dental degree from Tufts University, but also has a master's and a doctorate in public health. She's on the faculty at both Harvard and Boston universities, and head of the Department of Dental Public Health at Boston University. She's going to be talking to us about practicing evidence-based dentistry in clinical practice, and I think you will really enjoy her talk. So thank you again for joining us. I hope you appreciated tonight's lecture. We're really looking forward to seeing you on October 15th. And until then, stay safe and stay sane. Good night.